Awesome. All right. Well, thank you so much for having me today. I'm really excited to be here and give some updates. Please definitely feel free to, put questions in the Q&A section, and hopefully we'll get a chance to address some of those questions at the end. I think the slides, if I sort of run through them straight through, should still have 10 or 15 minutes at the end for answering questions. I'm going to start by talking about COVID in general and COVID vaccines in general, and then I'll try to really hone in on aspects of the COVID pandemic and the vaccines that are relevant to transplant patients. In the chat, I see that you are in fact from all over the country, and some even I think outside of the United States, and so this first slide doesn't completely apply to everyone. I'm, of course, based here in Philadelphia, so I'm always watching the COVID trends in Pennsylvania very closely. But truthfully, a lot of the trends throughout the country look sort of vaguely similar to this. This is looking at time, since the pandemic began last March, 2020, when we had that sort of initial spring surge here in the Northeast, and then things calmed down last summer. And then, of course, this past winter, we ended up having what turned out to be a much larger surge. Thankfully, likely due primarily to vaccinations, we have had, a notable decline in COVID cases here in Pennsylvania, as well as sort of throughout the country, this spring and summer. And so at some of our lowest rates this summer that we've seen in quite a while. So a lot of what we focus on now, rather than looking at COVID hotspots, is in fact looking at COVID vaccination rates. So now all the the photos and the graphics of the United States, in the news are actually showing you vaccination rates rather than COVID rates. This is from a few days ago. You can see the darker colors are parts of the country where a larger proportion of the population is vaccinated. So you can see there's quite a bit in the way of vaccination in the Northeast, as well as on the West Coast. There are some lighter areas, particularly sort of in the southern and sort of eastern, southeast part of this country, as well as some other pockets. The proportion of adults who are vaccinated, does vary quite a bit throughout the country. Here in Pennsylvania, just shy of about a half of adults are fully vaccinated, though in our city of Philadelphia here, the rates are quite a bit higher. So you can see even within this state, different cities, different pockets of the state or the region, can vary quite a bit in terms of vaccination rates. Interestingly, this is the map of the United States and where there's more COVID cases. So here, darker colors are COVID cases. Here, darker colors are vaccinations. And you can see that in general, these are sort of the inverse of one another. Where there's darker, more vaccination, there's fewer COVID cases. For example, on the West Coast and the Northeast, more vaccination, and there's sort of a lighter color here, fewer cases of COVID. And so we are seeing that in general, though maybe not down to the individual zip code, but in general, areas with more vaccination are seeing fewer cases, even right now when cases are not quite as high throughout the country. All right, so I'm really going to focus in on vaccination today, since that's definitely the topic that I get the most questions about in my own clinic, and the questions that were submitted ahead of time. So I'm going to go through some general concepts about the vaccines, and then I'll focus in on what we know about transplant patients. So there are 3 COVID-19 vaccines that are currently approved in the US, though they're all approved under this sort of emergency use category, or EUA, as it's called, which is just shy of being sort of fully approved. The 3, of course, which I'm sure you're all very familiar with, and which we generally seem to call by these names. There's the Pfizer-BioNTech vaccine, the Moderna vaccine, and the Johnson & Johnson vaccine. There are many other COVID vaccines out there, some of which are being used widely in other places like Europe. For example, the Oxford AstraZeneca vaccine at least was being used quite widely in Europe. There's also the Novavax vaccine, which is being developed here in the United States, and is in the final stages of testing, and so maybe another vaccine that's available in the coming months. But there's, over 50 different vaccines that have been, tested in one way or another, and could be coming, along over the next many months. All right, so to focus in first on the Pfizer and the Moderna vaccines, and I'm going to group these together throughout since they're very, very similar. And they're both, of course, these mRNA vaccines, as they're called. And so I have some patients who sort of think of these as the 2-shot vaccines and the 1-shot vaccines. These are the 2-shot vaccines. In terms of how these vaccines work, so this mRNA is basically a little snippet of genetic material, as is pictured in this diagram here. But it's just a little piece of genetic material. It's not a whole virus. It's just a tiny little piece that is actually in this sort of oily sphere, if you will. And when it's injected into your arm through the vaccine, it can move around your cells, and it can actually merge with your cells. And that genetic material goes inside the cells, and the cells then use that genetic material to make a protein. And that protein is a protein that COVID also produces. And so when that protein gets shown to your immune system reacts to this decoy. This isn't the real virus, it's just one protein. And your immune system can develop sort of a memory for what that protein looks like. And that way, when it comes in contact with the real virus, it sees that protein that it has a memory for, and then it can very quickly sort of activate and deal with the virus and prevent you from getting very sick or even infected at all. Importantly, this little bit of genetic material does not go anywhere near your DNA. And so there's a lot of concern initially about whether these vaccines might affect a person's DNA, but your DNA is in here in a cell nucleus, and this little genetic material from the vaccine stays out here. So they're not even sort of in the same part of the cell. The other thing that's important to know is that this little piece of genetic material, as I keep calling it, the mRNA, cannot give you COVID because it's just a tiny portion of the sort of entire COVID virus. It's just that one protein. And so there's not nearly enough information here to create an actual virus. So you can't get sick from it in the sense of getting the virus from it. And it does not affect your DNA. And there's a general feeling that these mRNA vaccines, which are sort of a new type of vaccine, sort of appeared very suddenly and were developed very rapidly and produced very rapidly. And do we really know what we need to about these vaccines? And I think it's worth knowing that the science behind these vaccines, has been developed over a very long time, well over a decade ago, that, different scientists, including one here at Penn, started working on these mRNA vaccines. And they've actually been studied for flu, Zika, rabies, and other viruses as vaccines. And so it is the first approved vaccine for mRNA vaccine, but it's not as if scientists just sort of pulled this out of thin air, a year and a half ago. It's a concept that people have been working on for a very long time. So in terms of how these mRNA vaccines performed, the Pfizer and the Moderna vaccines in the clinical trials, so they had really staggeringly good results with over 90% sort of efficacy, which means that if you had 100 people who would have gotten COVID infection, but you actually vaccinate all of them, only 10 get COVID infection instead. So a really superb reduction in the risk. Now I put an asterisk here though, because the clinical trials did not, of course, include transplant patients. So we don't know if this number applies to transplant patients or other immunosuppressed individuals. The other important thing that they showed in the clinical trials though was that the sort of full protection from the vaccine appeared to occur once you're about 2 weeks after your second dose. So that's why the CDC always says you're fully vaccinated 2 weeks after your second dose. It's because at that point they saw the sort of full protection from the immune system in the clinical trial study patients when they took blood from them and so on and looked at their antibodies and all those things. So that's where that idea comes from. There was some benefit seen after the first dose, some protection, but the full protection was seen 2 weeks after the second dose. In terms of side effects from these mRNA vaccines, this is sort of something that continues to evolve in terms of, whenever sort of any side effects are reported to the CDC or FDA about the mRNA vaccines, they look to see if there's sort of more of these side effects than one would expect in general to occur either after a vaccine of another kind, or just more than we just see in the population usually, and then start to investigate, if there is a causal link, and then we start to hear about it, from the CDC and FDA. And so there are still, some side effects that are being reported and highlighted now that we didn't know about initially. Though reassuringly, sort of almost all of these have been quite rare. And that's part of why it's taken so long to identify these side effects, because you needed to vaccinate, almost 200 million people in order to even notice that there was a signal there. All right, so what are the side effects? So very clearly, a lot of people get a sore arm after they get the shot. It's, swollen, it's red, it's painful. Particularly after the second shot, some people get symptoms that feel like the flu, where they're sort of tired, achy, headache, chills, fevers. Some people even have nausea and vomiting, but it usually only lasts a couple of days, and then people are sort of back to normal. And none of these have any sort of long-term repercussions for people. The other two sort of side effects that are much less common than these, but potentially more serious, are these two things here. So the first are allergic reactions. And the most serious kind of allergic reaction is what we call anaphylaxis, where you could potentially have trouble breathing and that sort of thing. And luckily, these reactions are very rare, but some people are in fact allergic to some of the components in the mRNA vaccine. And so this has been seen on occasion. And if you have anaphylaxis following your first mRNA shot, it is not recommended that you get another shot with an mRNA vaccine. The other sort of allergic reaction, in quotes, is this COVID arm, as it's been nicknamed. This is a picture of a study participant who had a COVID arm, and this has been seen more commonly with the Moderna vaccine than Pfizer, but I think it can happen with either. And this is sort of delayed. It happens a week or two after the shot, and all of a sudden the arm that wasn't painful becomes sort of red and swollen and painful. And this is a mild reaction in the sense of it's not life-threatening in any way. It comes and goes over the course of a couple of weeks. And it's perfectly safe to get a second shot, even if you had this sort of side effect from the first mRNA shot. The other side effect of these mRNA vaccines that we're learning more about is the so-called myocarditis or pericarditis, which are the fancy terms for inflammation of the heart or the heart lining. And this has been presenting primarily people who develop sort of chest pain, a couple of days after their mRNA vaccine. Sometimes some shortness of breath, but chest pain is the most common symptom. And it's mostly been seen in men and sort of adolescent or young men in the sort of 16 to 30-year-old range. And most of them have happened after the second dose, not the first one. There have been about 630 or so confirmed cases of myocarditis or pericarditis following the mRNA vaccine that was really thought there was no other clear cause of this heart inflammation other than the vaccine, which certainly sounds like a lot, but when you think about the hundreds of millions of people that have been vaccinated, it's actually a very, very small percentage of people. And reassuringly, there's been no deaths or sort of long-term complications related to these this heart inflammation side effect so far, anyway, that we know of. All right, so that's sort of the overview of the Pfizer and Moderna vaccines. Then the other vaccine, of course, is the Johnson & Johnson vaccine, and this is the one-shot vaccine. And this actually works very similarly to the mRNA vaccines in that there's a little bit of genetic material that encodes for this same COVID protein that's delivered to the cells, and then the cells use it to produce this protein, which they then show to the immune system. The immune system develops a memory for that protein and then can react when the real virus comes around. The main difference is just that this genetic material is actually packaged in a different virus, an adenovirus, as it's called. And they do that because this adenovirus is very good at getting into cells and delivering this genetic material. Now, this adenovirus, though, when used in a vaccine, has been altered so that it can't actually cause any illness. So you can't get sick from the adenovirus or this COVID related genetic material. But it's a sort of different delivery mechanism from the mRNA vaccines. But in the end, it does sort of accomplish a very similar thing. Similar to what I said about the mRNA vaccines, although a little bit of genetic material is delivered from this vaccine, it does not affect your own DNA, and it cannot give you COVID infection since there's not nearly enough information included in what's delivered to make a full virus. In terms of how well this vaccine protects patients, so in the clinical trials, it was about 72% effective, meaning, if you took 100 people who were going to get COVID and vaccinated all of them, you would have 28 who got COVID instead of all 100. Notably, it has not performed as well in other countries where other variants of COVID are circulating, and we'll come back to variants towards the end. But in the US, at least when the trial was done, this was its sort of efficacy. And I put an asterisk again, because again, transplant patients were not included in this trial. And here the protection appeared to have reached sort of its highest level somewhere between 2 and 4 weeks after the first dose. And so that's the reason for this 14 days after the first dose as the line at which you're considered fully vaccinated. In terms of side effects from the J&J vaccine, so there's sort of two. So on the one hand, fewer people experience the sore arm and the fevers and chills and nausea and that sort of side effect. But there have been sort of two rare but potentially serious side effects noted with this vaccine. So the first one is this blood clots with low platelets, and this is the sort of medical term for it. We abbreviate it TTS. But as you may recall from sort of the news in April, the CDC and FDA actually paused the use of the J&J vaccine because they are investigating these blood clots. And what they have found so far is that in general, this complication occurs in young women in sort of the 18 to 49-year-old range, generally a week or two after the vaccine. And there haven't been many cases at all, only 38 out of the millions of people who've gotten this vaccine, but there have been 2 of these individuals actually died, thought to be sort of complications related to this blood clot. And so that's, of course, a very concerning sort of signal. Again, it's just 2 out of millions, but 2 is probably too many. The vaccine is, of course, has been, is still recommended and still available in the United States. It hasn't been taken off the market or anything like that. But the FDA does now caution that women who are under 49 years old may be at slightly increased risk of a blood clot after this vaccine. And so it might be worth considering an alternative vaccine for people in that group. The other side effect that has just been getting some attention just in the last week or so have been these reports of what we call Guillain-Barré syndrome, which refers to a situation where after the vaccine, you develop muscle weakness. That's usually temporary, but on the severe end, it can actually lead to paralysis and occasionally some permanent nerve damage, though again, usually it's not that severe. These have been reported about 2 weeks after the J&J vaccine, and primarily in men over the age of 50. So you can see there's kind of in different age groups and genders and so on, there's sort of these different side effects that are emerging. And so it may be that in the future, depending on a person's sort of demographic information or other sort of illnesses or chronic diseases they have, one or different vaccines may be preferable. The Guillain-Barré syndrome, I do want to mention, is actually a known side effect of our complication that can occur with a lot of different vaccines. The flu vaccine is one of them. And so this is an association that we have seen with other vaccines before, though it doesn't make it any less kind of alarming. But again, it's been quite rare. Neither of these, the blood clots or the Guillain-Barré syndrome, have been reported with the mRNA vaccines. These have just been linked to the Johnson & Johnson vaccine. All right, so in terms of long-term side effects, there's sort of an ongoing concern that we haven't seen all of the possible side effects that are out there with these vaccines, and certainly, we don't know everything. I think, though, it would be incredibly unusual for there to be some long-term side effects that don't come up until months or years after having had the vaccine, primarily because in all the other vaccines that we give to kids and adults and so on, side effects almost always occur within about 6 weeks of having received the final dose of the vaccine. And so that's the reason why the FDA has a standard where it observes study participants for at least 8 weeks after a final dose of the vaccine, including all these COVID vaccines, and all the side effects that we have noted so far have happened in about that time frame. And the CDC, though, is monitoring people out longer than that. I'm actually about 6 months out from my vaccine, and I'm still getting those alerts to report if I've had any complications, but nothing beyond about 6 or 8 weeks has been reported. And there are, of course, now millions of people who have received the COVID vaccines, many of whom are now over 6 months out without any long-term side effects detected, though the CDC continues to monitor. All right, so at last, I want to sort of focus in on transplant patients and how things might be different for the transplant community compared to sort of the general population. So I guess to take a step back, why might transplant patients have any sort of different response to these vaccines? And the answer is the reason that we wonder about it is just because of the sort of long-term immunosuppression that transplant recipients use to prevent rejection of their organ. And that immunosuppression, of course, has a lot of important roles like preventing rejection and so on. But it's possible that in suppressing the immune system, you might also reduce how protective the vaccine is, because in order for a vaccine to protect you, when your cells see that vaccine, your immune system needs to react to it and get sort of revved up and make a response so that it can then have that memory. But if you're on immunosuppression such that your immune system doesn't really even react to the vaccine, to that sort of decoy, then there isn't a memory formed in your immune system. And so your immune system then doesn't know what to do when it encounters the real virus. And so it doesn't, the vaccine's not able to protect as much. So that's all theoretical, though. We don't know actually, how well the vaccines protect transplant patients. But I'm going to show you sort of what we have learned so far. I would say that we don't have a very clear answer yet on exactly how protected transplant patients are with these vaccines, but I'll show you sort of what we do know. So this was a study that was done by a group at Hopkins, where they took transplant recipients who just volunteered that they had had 2 doses of one of the mRNA vaccines, either the Pfizer or Moderna vaccine. And then the Hopkins researchers just drew their blood and checked for antibody responses in their blood. And what they found was that of 658 transplant patients, 54% of them had a detectable antibody response. So what that means is that a little over half of these people, of these transplant recipients, you could tell that they'd had the vaccine because their immune system had reacted and had this, antibody response, the antibodies being part of the immune system that help protect you against viruses. This is, of course, much lower than that 90% figure that I mentioned for the clinical trial participants. And so some folks found this sort of a demoralizing result. But I would say, for one thing, it means that actually a little over half of transplant patients did have a detectable response to the vaccine. And so it, not entirely in vain. And the other thing is that I don't think this study tells us everything we need to know. For one thing, measuring antibodies in the blood is not the same thing as knowing exactly how protected you are, because this really is just one measure of one part of the immune system and one part of the protection that you get from a vaccine. And so although it's sort of used sometimes to check if you're immune to things, it doesn't tell you the whole picture. And so we don't actually know exactly what level of antibody response equals protection. And we don't know if there's other parts of the immune response that would protect you even if your antibodies were low. And what we really want to know is how many transplant patients who've been vaccinated actually get COVID anyway, and severe COVID at that. Sort of, if you get COVID but just look like a usual cold, that's fine. We don't necessarily need to prevent colds. We just don't want to, we want to prevent pneumonia and sort of severe infection. Importantly, though, in all of these patients, they didn't see any new or unusual side effects of the vaccine. So this was reassuring that these vaccines didn't appear to affect transplant patients in a negative way, in any sort of different way than the general population. So this has led to a lot of discussion about whether transplant patients need a third dose of these COVID vaccines. And this is definitely the single most common question that I get right now from patients. So what do we know about a third dose and whether it's potentially useful, dangerous, et cetera? So from the same group at Hopkins, they've reported on so far 30 transplant recipients who were given a third dose of one of the COVID vaccines. All of these people had a minimal response to the first 2 mRNA shots, but the third shot that they got really varied. This wasn't actually something where the researchers administered, a specific vaccine at a specific time to the patients. This was just they reached out to their transplant population, said, if you're someone who's gone ahead and gotten a third dose from somewhere, let us know, and we'll want to see sort of what happened. So some patients got a Johnson & Johnson vaccine for the third one, some got a third dose of the mRNA vaccine, and I don't believe, I think there's some cases where there was mixes and matching. So some people, got 2 Pfizer vaccines and then a Moderna, or 2 Moderna and then a Pfizer, 2 Moderna and then a Johnson & Johnson, and sort of each one of those potential permutations. And so what they saw was that after a third dose of the vaccine, there were 10 of these 30 patients, so a third of them did have sort of a new detectable antibody response that they hadn't had before. 20 of them still did not have an antibody response that could be measured, but this appeared to increase the number of patients who did have a detectable antibody. Notably, there was one patient who got a third vaccine shot who then developed rejection, which is always sort of a concern of ours when giving vaccines. Since vaccines do sort of rev up the immune system, we always worry that that could cause rejection. This was just one case out of 30, and it was very unclear if it was related at all to the vaccine. In fact, it was generally thought by the doctors taking care of the patient that it wasn't, though it can be hard sometimes to know for sure. This study, though, of course, is limited by the fact that only 30 patients were studied. We generally like to look at hundreds, if not thousands, of people before we draw any conclusions about things. And then the sort of different regimens that these patients all got makes it a little bit hard to draw conclusions about what works best. And then again, this was just measuring those antibody levels in the blood. It wasn't really getting at how protected our transplant recipients after a third shot. So this study was the next one to come out. This is a study from France looking at the use of a third dose of the COVID vaccine for transplant patients. And for this study, so in France, the French National Authority for Health, which is sort of like the CDC in this country, they recommended a third dose of the mRNA vaccine to immunosuppressed individuals living in France. And so they reported on 101 transplant recipients who got 3 doses of the Pfizer vaccine. And the third dose was given 2 months after the second dose. So there was a shot, waited a month, a shot, and waited 2 months, and then a third shot. And what they found was that essentially more people had antibodies detectable after that third shot. So you can see after 2 doses, 40% had antibodies detected in their blood, and after a third dose, 68% had antibodies detected in their blood. So now 68% is a very reasonable sort of number and goal for in vaccine studies when you're looking at efficacy. So that does seem to increase the number of transplant recipients who have detectable antibodies. And they did not have any episodes of rejection in their 101 patients who they followed. But importantly, this is still a small number of transplant recipients. As I mentioned, we want hundreds or even thousands, if possible, before we make any conclusions. And again, this is all just looking at antibodies in the blood. It's not looking at protection rates. What we really want to know, which none of the studies so far that I've mentioned have really addressed, is how are these breakthrough infections? So how many people who are fully vaccinated still end up getting COVID? And even more importantly, what proportion of those people actually get very sick with COVID and have to go to the hospital and so forth? Because that's what we really need to prevent. So in the United States at large, about 10,000 breakthrough infections have been reported, which sounds like a big number, but when you, again, divide by the number of people who are vaccinated, which is, I think over 170 million at this point, you're really talking actually about a very small percentage, less than 1%. And the majority of those who have these breakthrough infections have had very mild infection with 0.0025%, so a very small number requiring hospitalization or dying from COVID. We, of course, expect some amount of breakthrough infection. No vaccine is 100% effective. As I've mentioned before, if the vaccine is nearly 100% effective at preventing sort of severe infection, then that's really pretty excellent. And that's actually what's been, at least so far, observed in the United States. It remains the question, that we're all trying to figure out, though, is are these breakthrough infections more common in sort of immunosuppressed people, such as transplant patients? And there was one study that was just recently published based out of the Yale New Haven Hospital system, where they looked at all of their transplant patients who they currently follow, which is about 2,000 transplant recipients. And, they follow more than that, but 2,000 of them have been vaccinated for COVID. The vast majority of those recipients had received one of the mRNA vaccines. And what they found was that in terms of breakthrough infections, there were only 6 cases of COVID, which was 6% of the transplant patients they follow, among those that were partially vaccinated. And there were only 3 COVID cases among those that were fully vaccinated. So less than 1% of the vaccinated transplant patients actually had a breakthrough infection with COVID. And all 3 of these individuals had mild illness and survived. This would suggest that perhaps even if you don't have a high antibody level in your blood, you may still be protected somewhat, since less than 1% of these transplant patients developed a breakthrough COVID infection. Now, I will say, so for comparison, you'll find different figures on this, but at the moment, the CDC says that about 0.001% of the general population experiences breakthrough infections. And so the sort of alarmist way to frame this is that transplant recipients have 650 times the risk of the general population of having a breakthrough infection. But when you look at the absolute numbers, you see that in both cases, it's less than 1%. So it's a really tiny percentage, for the general population and for transplant patients, at least in this study. So I'm not sure that we really know yet how protected transplant patients are, and they may be more protected than is implied by the antibody studies. But I guess the other thing to keep in mind is that, these patients who had very few breakthrough infections may also have been very cautious in terms of using masks and social distancing and so on, which you can't quite account for, in this study. But that's, I think, very reassuring data about how the vaccines protect transplant patients. So based on that sort of array of information, the American Society of Transplantation is sort of continually trying to make recommendations about COVID vaccines for transplant recipients and candidates. This is a reference that gets updated regularly, and I would definitely recommend periodically checking in on this to see what the new recommendations are, since this is sort of the the body of transplant, physicians and professionals who will likely sort of set guidelines, if you want to call it that, for transplant patients. Now, you'll see actually they haven't been updated now in a couple of months, but at the moment, these are the current recommendations, which is that, of course, we recommend all candidates and recipients be vaccinated, ideally before transplant if possible, just because your immune system's a little more active then. But if it's not possible before transplant, then we usually wait at least 1 month, if not 6 months after transplant to give the vaccine, as that sort of initial immunosuppression sort of dies down a little bit, since a lot of immunosuppression is given right at the time of transplants. And all of the COVID vaccines that are approved in the US are not live viruses, and so there's no particular safety concerns unique to transplant patients. The American Society of Transplantation does caution in their guidelines that transplant patients after being vaccinated may still be more vulnerable to COVID infection than the general population, and so does recommend continuing to use masks and socially distance and so on, regardless of your vaccination status. And I think one important thing is to ensure that household members and caregivers are vaccinated, since the sort of most common source of kind of an outbreak is when one person in a household gets COVID. It's very common for it to then be spread throughout the household. So if a household is completely vaccinated, then that will protect the transplant recipients. At the moment, we are not recommending checking whether you had an antibody response to the vaccine, and not recommending a third booster shot of the vaccine. The approval from the FDA, this EUA or emergency use authorization from the FDA for these vaccines actually does not include a third shot. So it's not actually within your doctor's sort of ability to recommend or prescribe or anything a third shot right now, since the FDA has not included that in this EUA, as we call it, so in the guidelines for how to use these vaccines. And we don't recommend checking the antibody response right now because it's hard to know what to do with that information. Regardless of whether your antibodies are high or low or in the middle, we would still, recommend getting the standard vaccine, and then recommend remaining cautious, as if you may still be slightly more vulnerable. And that's going to be true regardless of what that antibody response shows. At the moment anyway. And we don't recommend at the moment changing immunosuppression at the time of vaccination. There's been this possible association that if you're on mycophenolate or azathioprine in particular, maybe the immune response is slightly less robust to the vaccine, and so you're slightly less protected, but that may just be a marker of sort of how immunosuppressed someone is in total, rather than due to that particular medication. So at the moment, the American Society of Transplantation does not recommend changing immunosuppression at the time of vaccination, though I know additional studies are being done to try to understand whether different immunosuppression medications do impact protection rates. All right, so just the last few sort of topics before we open things up for questions. So I wanted to touch on variants, since this is, the source of most headlines in the news these days. And certainly it's a little bit confusing, but in general, the variants refer to sort of different strains of COVID, where, the vast majority of the virus is the same, but there have been little changes to its genetic material that result in slight changes in how it behaves. These variants are very common. We see this with all viruses. As they replicate and spread, they always evolve a little bit. There's sort of 4 main variants that have received a lot of attention, though there are hundreds of variants out there for COVID that have been described. But these 4 here are the ones that have become sort of common, and so have thought to be particularly relevant to our health and the pandemic. They started by referring to where the variant was originally identified, like the UK variant or the South Africa variant. Then we sort of switched to this lineage, the B117 variant nomenclature, and now we seem to be trying to simplify things by calling them by just alpha, beta, gamma, or delta. Delta is, of course, the variant that is receiving the most attention currently. I think we're definitely still trying to understand the relevance and importance or lack thereof of each one of these variants. It is pretty clear that each one of these variants was sort of more contagious than the one before it, and that's how it became, a dominant type of virus circulating. Just by being more contagious, it just spreads more easily, and then all of a sudden it becomes the virus that everyone's infected with. Whether or not it leads to more severe infection with each one of these variants is less clear. There's some studies that suggest that maybe the Delta variant does cause more severe infection in unvaccinated individuals, but I don't think that's sort of conclusive as of yet. And reassuringly, so far, the studies that have been done do suggest that all of the vaccines available in the United States are active against, in protecting against all of these variants. I would think of protection rather than as being you're either protected or you're not. I would think of it more as a spectrum of how protected you are. And I think that these different variants may chip away a little bit at how protected we are by the vaccines, but because particularly the mRNA vaccines, we're sort of so protected to begin with, even if you chip away at it, there's still quite a bit of protection there. And so at the moment, the emphasis is really still on just trying to get the most people vaccinated as possible, rather than getting new vaccines out there, since the current ones seem to work if we can get the majority of the population vaccinated. All right, so I'm going to sort of finish by just mentioning a few things about, so if you're vaccinated and transplant recipient, what is it safe to do? Because this is definitely a little bit confusing. And my answers today may not be super satisfying, because I think the truth is that we're not entirely sure, exactly how well protected transplant patients are with the vaccine. But the CDC, just says one sort of little thing about, people who may be immunosuppressed. They say that you should talk to your healthcare provider to discuss your activities. So that's fine. And they say you may need to keep taking all precautions to prevent COVID-19. So they sort of sneak in this recommendation that maybe you should, sort of keep acting as if you're not vaccinated, even if you are. I think what our group, at least, is recommending at the moment for transplant recipients is that, well, one, you do get vaccinated. That's probably the most important thing. But even after getting vaccinated, because we're still trying to understand exactly how well protected you are, we are recommending that you continue to use some of the, the important precautions that we've all learned over the last, 18 months. Wearing a mask when you're around people who aren't in your household or aren't vaccinated, washing your hands frequently, social distancing. And I think if I had to pick one thing that I would have my transplant patients, still avoid, even if they're fully vaccinated, it's this down here. So crowded and poorly ventilated spaces. So basically being indoors with a large crowd, that seems to be the scenario in which COVID is most likely to spread and cause outbreaks and so on. And so things like bars or movie theaters where there's a lot of other people, those other people, you don't know their vaccination status, they may or may not be wearing masks, and it's not well ventilated because it's indoors rather than outdoors. That's certainly higher risk and probably something that I would still recommend that my transplant recipients avoid, even if they are fully vaccinated. On the flip side, outdoor settings are clearly much safer. Very few, if any, sort of spread of COVID has been documented from purely outdoor interactions. So I think that's a much safer alternative to these indoor crowded scenarios. So this was a COVID-19 risk index that a group at Penn put together in front of before we had vaccines. But I think that I still think this is relatively sort of generally accurate scheme of kind of how low or high risk activities may be. And I think that for transplant recipients, even if vaccinated, I would still probably avoid, some of these higher risk activities that again involve sort of indoor crowded activities like, bars or movie theaters. In terms of traveling, this has come up a lot this summer, since of course we're all kind of eager to see some new scenery besides just the inside of our house or apartments. So currently in the US, there's no COVID testing required for travel within the US. But perhaps a good thing, masks are required for everyone on public transportation, regardless of vaccination status. And so that's sort of helpful for transplant recipients since it means that everyone has to wear a mask around you. In general, if you're a vaccinated transplant recipient and so not quite sure how well protected you are, but would like to travel, we're generally recommending some of these sort of safety precautions that can just make it slightly safer when doing that traveling. So, for example, driving in your own car with only those people from your household or only vaccinated individuals where you really know that they're vaccinated can improve safety. If you need to use public transportation, just sort of minimize the time that's spent on public transportation, as well as rest stops or layovers, that kind of thing. And perhaps more important than all of that is when you're away and staying somewhere outside of your home, you want to stay with people who either live with you normally or in your household, or people who are fully vaccinated, since again that protects you. All right, so this is the last slide, and I'm realizing we only have about 5 or 10 minutes left. So these were questions that have been submitted that I just wanted to sort of reiterate the answers to, since I think these come up a lot. The first was about whether organ recipients should get the COVID vaccine when they're showing signs of rejection or on new anti-rejection medications. And certainly you'd want to talk to your particular providers about this question, but in general, we recommend getting your vaccines when you're on sort of a steady amount of immunosuppression and not in the midst of a rejection episode, just because we worry, one, that the vaccine could make rejection worse potentially, and two, if you're getting a lot of new rejection medicines, your immune system might be more suppressed than usual, and so you might get less protection from the vaccine. The second question was about, family members of the transplants recipients going back to school or the office. And in general, we recommend, for example, children returning to in-person school, if they just sort of follow the standard precautions put in place in school, whether it's masks or, weekly COVID tests or that sort of thing, there isn't necessarily any extra precautions that are needed within the household, unless that child or other person who's returned to school or work starts feeling ill. In that case, we would isolate the transplant recipient from the person who's feeling sick until a COVID test could be performed. There's a question about what our experience has been for transplant recipients who have been vaccinated but have developed a breakthrough infection with COVID-19. And I think that study from Yale that I mentioned sort of sums it up well, which is that we have seen this occur much in the general population too, where we have breakthrough infections. But in general, they have seemed to be more mild in terms of how, the severity of the illness when they get COVID. And then finally, do you recommend vaccinated transplant recipients get tested for COVID antibodies? If not, why not? And I think at the moment, we're not recommending it just because we're not really sure what to do with the results of that test. But I would say stay tuned, because over time, as we learn how to interpret those tests better and maybe get additional tests that measure other parts of the immune system, we may get a better handle on what to do with the results of that, and it could end up being helpful.